I would like to say hello to everybody and welcome to our educational platform, Pelvic Academy. This is our third session in trainings, and we are together with Dr. Endungo again a second time. I hope that you will find his presentation very interesting, beneficial, and exciting, hopefully. He will begin in a few minutes, and we will be all together during the 40, 50, 60 minutes during the presentation. And after the presentation, he will answer the questions. Meantime, I will be glad if you can write your questions in questions and answers part. And we are starting, Abdullah. Welcome again, and thank you for your support to the trainings of our physiotherapists and our specialists in different specialties in doctors also we have as participants here. And we are expecting to increase the number of doctors who believes the benefits of pelvic floor rehabilitation. And also we would like to have more physiotherapists very well educated in pelvic floor rehabilitation. So thank you for your support again.
It is my great pleasure as usual.
Thank you. And now the ball is on your side.
Thank you very much. I'm ready to catch the ball. And first of all, I would like to thank again the Pelvic Academy in Turkey. I would like to thank you, the organizers. It's exciting.
Thank you.
Who plays a key role for the life of women, but not only women, but as well as men, to improve their quality of life, especially after pelvic floor dysfunctions. So I would like to send my greetings to all friends in Istanbul, in Ankara, and in all parts in Turkey, because you guys made this journey, this night on Friday, special night for all of us. And I'm going to use the opportunity, first of all, to pass my greeting to all of you with respect. And I'm going to share with you what I've been doing and what I keep on doing all these 15 to almost 20 years of my studies. And more importantly, I would like also to share my experience clinically to all of you. So first of all, my greetings to all my friends, doctors and physiotherapists in Turkey. You guys are amazing. You have a beautiful country, and you are really a connection to the world. So I'm learning a lot of things from you guys. Thanks a lot. And I'm waiting just to have, of course, a good time post-COVID, and then we will meet again by the will of God. Secondly, I would like also to thank all of you to be there, but we have also a lot of friends in different parts of the world. I can say in Europe, for example, we have some in Poland, here in France, in Belgium, and in different countries in Europe who are just watching now. And some of them will come as soon as possible. They will be there. And we have also a lot of friends in Asia, in Mongolia, for example. I know they are watching now. It's too late there, but they are there. They are watching. Some of them, they're in China, in different parts of the country. So I use this opportunity to greet all those friends in different parts of the world, in US, in Canada, in Africa, and all over the world. So thank you very much for all of you for being here. And we are going to share together this topic, which is, as you can see, it's a multidisciplinary topic, which not only brings together different specialties, whether you are obstetrician or gynecologist, whether you are gastroenterologist, whether you are urologist, whether you are a surgeon in this field of the pelvic, or whether you are a physiotherapist who take care of all of these specialties. Together, you can see we are really a team. Only when we are united, I will start with that, then we will be able to understand, because most of the things, we do not understand much about what's going on. This topic is complex. So I'm going to share with you, to use different view according to my experience. But before really I start, I would like to say a great thank to my professor who really taught me the knowledge of medicine. Each time I come in front of an audience, the first things I remember Of course, my parents are very important back home. Some of them, they're watching now, but my friends as well. But more importantly as well is my professors. Especially there is one name which comes in my mind all over, is Professor Ling Zhong Cho from Sun Yat-sen Memorial Hospital in China, in Guangzhou, who treat me, you know, who really treat me as his son, and he gave me an opportunity to learn medicine, especially in oncogynecology. This is why today's topic really is related to what I have learned for so long. And we are going to see that doing these surgeries in the field of obstetric and gynecology, or urologists or urogynecologists, actually, especially the patient who will undergo major surgeries, we are going to learn later on their quality of life matters. That means after cancer, there is life as well. So we need to improve their quality of life. This topic is gonna go through these ways. So you can see here, I prepare some programs for you. And the first part of my program tonight, because it's a little bit night here in France and even there in Istanbul, we are going first to see the overall view of global pelvic organs functions. And then we will learn about the characteristic of these regions. What made this region so special? And on my second part, I will talk about the overall view of surgeries in this field, in these areas. We know there are multiple organs in this area. We have multidisciplinary in this field. So how do they operate? What kind of surgeries do they do? And what is the outcome of these surgeries? And then on my third position, my third point, I will be talking and sharing with you about the overall view of pelvic floor rehabilitation. Because of course, for physiotherapists who are specialized in pelvic floor rehabilitation, they know what is pelvic floor rehabilitation. They know how do they work, that's right? I will just add on that some ingredients on what about the new technology? What about the dynamic kind of treatment we can do? What is up to date, which is efficient and proven? Or what are the techniques we use in different parts of the world? Can we share together our experience? So I will be talking about in that part. But we should never forget that obstetrician and gynecologists or urologists or gastroenterologists or these surgeons, this is not really their field. They really understand how to do their surgery in the best way. But when it comes to pelvic floor rehabilitation, this is a specialty of the physiotherapists in this field. So here I'm just trying to make a bridge between specialties so that we can have the multidisciplinary approach. We can speak in the same language because we are treating the same patients. So our approaches should work together to improve the quality of life of these patients. On my fourth point, I will be talking about the pelvic floor rehabilitation in a pre-surgical treatment. That means pre-operative period. What is the aim of such pelvic floor rehabilitation? Are we really doing the rehabilitation or are we educating? Are we preparing or are we treating the symptoms? So it's so important because there are especially patients who will go major surgeries. It's so important to prepare them to the outcome of such a task, such a difficult situation, which is the major surgery. So I will be introducing to you the aim of a pre-surgical treatment. How do we do it? What is the aim? And what is the outcome? How can the patient use the benefits of the pre-surgical pelvic floor rehabilitation? On my fifth point, I will be talking about the changes after pelvic floor surgeries, the outcomes, the consequences, and of course the good news as well. And on my sixth point, I will be talking about the pelvic floor rehabilitation in post-surgical treatment. Now, this patient has underwent, surgery. She has undergone surgery. So what kind of pelvic floor rehabilitation are we going to do at that particular moment? Is it the same as the pre-surgical treatment? That is the one. And then later on, I will conclude my topic, and then I will invite you, please, if you have questions related to the topic we are going to have tonight, please feel free to put it on the question and answers. So later on, I can come through your questions and try to enlighten and answer them in the proper manner, according, of course, to the little knowledge I have. I can say that. So please forgive me if sometimes I'm a little bit faster. So do not feel free to write something there. And I would like to ask Ceze setting sometimes to go to read those questions whenever there is something or some suggestions, so that you can enlighten me, so that I can do the proper manner, so that everybody can get through this topic, the meaning, and then go back with something behind. So first, let's start with the overall view of pelvic floor organs. Here, I will be talking about the functions as well. They are organs which are there, but their aim is to have some functions. And then I'm going to talk a little bit in the global view of this region to try to explain about different organs, functions, and how do they operate together in a multidisciplinary approach in some ways. So my first introduction started with regardless the gender, whether we are male or female. Human pelvis represent a complex anatomic region shared by organs, different organs. For example, the organs of reproductive system, the uterus, the ovaries, the fallopian tubes, this uterus, cervix, vagina. This area, we call it reproductive system. We have the gastroenteral ligament from the posterior side, the intestines. We have the anal, the rectal, but as well, we have the genital urinary tract as well, which is connected to the bladder, to the urethra, and of course the kidney. They work together to make sure that this area is working in a region. Just when you look to my first paragraph, we understand that they are this population in the pelvic, we can call it, they have neighborhoods. There is some neighborhood between these organs. They live in the same area. That means they share some rules together. It's so important to keep that in mind, because whenever this neighborhood is in trouble, sometimes the problems come from the neighbors, but the impact of the matter may be operating on the other guy. That means, for example, if the posterior part of the bladder anatomical changes, it can create some kind of cystocele. It is the prolapses of the anterior vaginal wall, for example. And I will give another example, for example. These organs, they have ligaments, the attachments, which help them to remain in a normal position. Whenever these ligaments lose their elasticity or their functions, and these organs will find itself at abnormal stabilities, and whenever there is intra-abdominal pressure, this organ can move further than according to the rules which were operating in that region. That means the stability of the pelvis. So we can see there is a relationship between the organs. It's not just an organ which has its own function, but these organs also, they cooperate together according to the fascia which unite them, or the ligaments inside the pelvis. All these structures are including inside the pelvis, that these bone parts which help to, to protect, we can call it, but it is also a bridge when it's come to the upper part of the body and the lower part of the body. So pelvis is also connected to the upper part and the lower part of our body. On my introductions, also, I would like to mention that the pelvic regions occupies the center part of our body. The word center just tells us that it is a key area in our body. Because it is central, that means a lot of things, there are a lot of connections pass through the pelvis. Different organs with different functions share the same region. There is a location, organs, and the relationship I was talking about in my just previous slide. And then here I would like also to talk about the pelvic organs functions are directly related to our quality of life. For example, every day we need to pee, that's right, to go to toilet. That means our life conditions, our behavior is directly connected to our pelvic. Whenever this pelvic is living a challenging time, this will affect our psychology, our behavior, and our way of life. So the quality of life can become poor whenever the pelvic floor has some kind of dysfunctions. And the changes during lifetime, that means we are getting old, the age, the pelvic trauma or major or minor kind of surgeries we may have during our lifetime. All of these together, since we were born until we live, we are old. We're women who you know, who gave birth 1 or 2 times in difficult conditions, according to her past and her history, a man who has a trauma in the pelvic, or whenever he has a prostatectomy or any surgery in this region, all of these, you know, trauma or life challenges during our lifetime, all of these are going to affect later on, sooner or later, sometimes the quality or the stability of the pelvic. That means our quality of life in the future. There are possibilities to improve the quality of life of patients in pre and per or even post surgical treatment. It means here, if we know we will get old sooner or later, we know that. We know that our lifestyles, we are used to carry heavy stuff, for example. This is bad behavior we have been used to, or our posture is not so stable. We know that we have been coughing for so long or carrying heavy stuff, or we, with our lifetime, we had some trauma, whether it is after pregnancy or after any kind of surgery. So if we do not pay attention to help these regions to keep a good stability in a long term, it's just a matter of time, these patients are going to suffer from the symptoms we understand, which is anteriorly, whether it is urinary incontinence or whether it is medially sexual dysfunction or prolapses or any kind of chronic pelvic pain, or these patients might also have some symptoms related to anorectal, or even when some of them, they may have coccygodynia, which is a pain into the coccyx after, for example, a trauma, a person's giving birth, or sometimes whenever, you know, you fall down to the coccyx, you can have also some trauma on the sacrococcygous junctions. But because we know that from the pubic bone to the coccyx, all our pelvic floor muscles, I'm talking about deep pelvic floor, even superficial pelvic floor muscles, like the pubovagina, pivorectalis, iliococcygeus, ixiococcygeus, all these coccygeus muscles, they are related and connected together with our bone parts, the pelvis, whether it is the pubic and the coccyx. This is how they are going to find themselves in a very unusual situation. That means they become hypertonic, they become harder, but we do not forget that it's not becoming harder means good function, because most of the time we need them to relax. For example, when we are peeing, our pelvic floor should be completely relaxed. But since this person has, you know, the risk of trauma from the coccyx or from any pelvic area, these muscles cannot relax anymore. They are in hypertonic positions. Later on, they will develop some trauma and the concepts of symptoms, which is syndromes, whether it is pain or whether it is the patient may have a constipation in the posteriorly, or they can even develop some kind of incontinence. So you can see here the stability of these regions and all the organs and the elements which made these specific regions. Every player is so important to make sure that this pelvic area remain at the stable position. On my preview intervention we had last time, our video, I talked about the team, the pelvic team, if you remember. And those who were not here, I'm just saying here, every player, whether it is ligaments, fascia, muscles, organs, all the nerves, and the vascular system, all of them, they are important to take part to the stability. Whenever one player is not at the right position and on the function is not correct, it can affect one organ or multiple organs, and then later on, it may affect the quality of life. Sorry. Then this picture here, we can see every component, you know, is important. Every element. On my first, we can see on top the organs. We can see the ligaments joined together. We can see the deep and superficial pelvic floor muscles. All of them, including from the obturator area and the regions. All of these organs together live together in this neighborhood, we can call it, and it's so important for them to keep the stability. We need them to keep in a normal position, so that means we need the ligaments which will help them to remain. For example, from the delancet these levers. We have level 1 and level 2 and level 3. We know that these organs from the anterior and from laterally, they need to posterior, they need to remain at least at a normal range position. I'm not talking about a static position, because pelvic is not static. Pelvic is itself moving, but moving with a normal range. There is here the range. That means you can move, but you cannot move too much. It's becoming a problem. And secondly, whenever it does not move, it's a problem also static. Muscles, they need to contract, they need to relax. These things should happen in a very good manner, and all the reflexes should participate. I talked about lifestyle, and in our past, whenever we have a bad lifestyle, obesity, different kind of pregnancy. Here, pregnancy, I'm not saying whenever a woman is pregnant, that is a problem. I'm not saying that. I'm saying that if that pregnancy, we did not help these patients to gain a normal range of weight during her pregnancy. For example, we often say between 12 to 14 kilograms. But imagine a patient in the last 3 to 4 months of her pregnancy, she gained 20 kilograms. You know, this dramatic changing in a short period of time, that's gonna be a problem. It's gonna, it's gonna unbalance the stability in pelvic. And then another thing here, we should understand that surgery also intervene. Of course, surgeries are made sometimes to save lives. Sometimes we need them. But behind or after surgery, we have also life. It's not just like a point of time in our life which matters, but also what should happen in post-surgery. And our age, no matter what, each day pass, the clock is ticking. Of course, our body is getting old. That is the bad news, but also it's a good news, we become mature. So a person who is well prepared and keep the balance, the question is how to prepare well. This is what we will be talking about on pre and post surgery. How can we help these patients after such a life trauma, whether it is surgery or not? How can we help them to regain control and to improve their quality of life? When we look at this picture, we can see this lovely baby is, is staying in this area, but the muscles in the abdomen will also feel it. Of course, they have some hormones, elastin, which participate to make these muscles become more elastic. These organs in this region are also will try to, to adapt to a new condition during this 9 months of pregnancies. But imagine this patient before she gets pregnant, she has a kind of constipation, for example, or she had a high risk of pelvic floor dysfunction even before her pregnancy. So for her, the pregnancy will become another kind of challenge. So we need to help these patients to prepare their new pregnancies, or even to help them during their pregnancy, and especially in postpartum, so that they can regain control of their bodies and then have their balance. I will talk about the quick view about neurology in the pelvic organs. We should understand that because we will talk about pelvic floor rehabilitation in post-surgery. But how can we talk about this topic if we don't really connect how these organs in the pelvics are connected together? How are they controlled? Who control them? In which part can we help? Can we try to help these organs to regain their stabilities? So we need to understand these pelvic organs, they are also connected to our brain. There is a common, the central part. It is the superior and the medullar part. So we have the superior and the medullar part which control the pelvic area. Secondly, we have the motor pathway. The motor pathway here, we need to understand that, of course, the central part or the medullar part is connected to the peripheral part through this motor pathway. We have the efferents and we have also the afferents area. And we have different reflexes in the pelvic regions, which also works together to prevent these patients or this person to have different kind of pelvic symptoms. So from the superior part, I'm talking about the central part, we have the first part, the message arrives. That means whenever our bladder is starting to fill and reach to a certain level, for example, 200 cc or 300 cc inside our bladder, milliliters, I'm talking about milliliters, then the message comes to the cortical centers. And then after that, this message will go to the subcortical. Cortical center will know that, oh, there is something in my bladder, but what is it? So it will send a message to the second part, the central center, we call the subcortical center. And this part now will analyze, filtrate the message to say, okay, if it's, for example, in the rectal and anal, it will say, this is gas, okay? Or this is liquid, or this is solid. We know and we are sure inside our rectum, it's gas. Nobody has put his eyes there to go to see what's inside. But we are sure we got the message. And we know now we are not wrong. This is gas. And since you know it's gas, you are free in the street, wherever you are, according to the culture, now you have to decide what to do. Do you decide to remove, let it go or not? You will send your message to the message number 3, the bladder activation, to let it go, or you will decide to urinate, not to urinate. That means you will send the message to the cerebral center. So remember, the brain is under control, even when sometimes the autonomous system participates, but the message is clear from the center 1 to the center 2 especially. The message is so clear. It's like we receive a letter, but inside the letter, we don't know what is the message. So the first part, the first station is center 1, cortical center. I know there is a message coming from the bladder, or there is a message coming from the rectum, but I don't know what is inside the envelope. I will send this envelope to the second part, which is subcortical. This subcortical, what it does, it's open the envelope and read the message inside and tell the person, it is your bladder is full. It's time for you to go to pee. Do you want to do it or not? Now the decision making, it's up to you. While you are working on your computer, you decide not to go. Then you will send a message to number 4, which is the cerebral center. If you decide to go, you will send the signal to the bladder activating. That means you will go to toilet, you will relax, and then you will start to push a little bit, and then all the things will go together in a good manner, according to the normal way of function. But don't forget, our patients sometimes, their pelvic floor is not in a good manner. That means their muscles, maybe they are hypertonic or they are weak. That means they do not have time to bear and to wait until you reach to the toilet. This is when they will have the pelvic floor dysfunction. We have some patients also who have trouble to read the message. That means they know their bladder is full, but they don't know how much is it. Is it emergency or can they wait? Those ones are going to develop overflow because they cannot quantify the sensitivity. The receptors are not doing their job. Maybe after a huge or major surgery or after any kind of trauma. And there are other patients who cannot make a difference between gas, solid, and liquid. That means their receptors, when it comes to the upper part of the anal, connected to the inhibitory reflex, is damaged. This, we call it the rectal anal inhibitory reflex, is not working properly. They will develop some kind of constipation and so on. So we should understand that the centra is in command, but it's in coordination with the external part in the pelvic, and all these things should work together as a team to make sure that a person can have a normal function. In the medullary part, that means I'm going to the centra, but medullary part. Here we have a sympathetic system, the sympathetic system, parasympathetic system. We have the somatic system, and which work together. The sympathetic is about the T10, L2. Parasympathetic is S2, S3, S4. And in the somatic system, which is also is S2, S3, S4. Different corners, but in the same level. And from the sympathetic system, the nerve, we call it the hypogastric nerve. Parasympathetic system, that nerve, we call it the pelvic nerve. And then the somatic system, that is the penile nerve. These are, the first two are autonomous. We call them vegetative ones, sympathetic and parasympathetic. And the third one, the somatic one, which is not only it is motor, but as well it is sensitive. We look at this picture to try to understand what I'm talking about. We can see on my picture here on my slide that from the center part, you have the bladder here, and you can see that this is at the level of T10 to L2. You have the sympathetic system, which is the hypogastric nerve. And this hypogastric nerve have different receptors. We have the betas and the alpha. They are more beta in the bladder detrusor, and we have the alpha, more alpha when it comes to the internal parts of the urethra. And at the same time, we can see the other part, which is parasympathetic system, S2, S3, S4. It's got a nerve we call the pelvic nerve here, you can see. And then also it's got some receptors, which are the M2 receptors, which help whenever the parasympathetic system is stimulated, the bladder detrusor will contract. This is how we avoid it. And whenever the sympathetic system is activated, the bladder will relax, and then the bladder neck will close, the bladder detrusor will relax, the amount of urine will increasing, so we can control and storage. But remember, the bladder was not made there to keep longer the urine. Whenever the size and the amount reach to a certain level, it is time to void. So we need to have a good habit on such a kind of life. Whenever we do not have such a good habit, that might affect, of course, the functionality in the long term. It becomes, whenever we lose the balance, it becomes pathology. And the last part, which is the somatic, we can see here, this is where the pinudal nerve, which is connecting to our pelvic floor, which is also motor and, as we said, and sensitive. So controlling by the pelvic floor rehabilitation. This is why when we do pelvic floor rehabilitation, we try to strengthen these parts and to make sure that it can help this person to remain in a good range. This picture here, I like just what I'm saying here. We can see those different systems working together to make sure that this person can have a normal function. We should never forget, this is an example. I was talking about the bladder and the urethra. You should not forget, from the back, we have the anal and the rectum in the same manner. They use also the same systems, which has the same functions. As we can see here, whenever the sympathetic system is activated, the parasympathetic system is inhibited. And we can see here, the rectum is relaxed, the anal is closed, and then we are at the storage area. And then whenever we are defecating, for example, it is the opposite. The parasympathetic system stimulate. There are different reflexes when it comes to the anorectal functions, and all these reflexes work together in coordination. Of course, coordination with also the pelvic floor, everything with our mind, which help the person whenever you are inside the toilet, for example, you can go and relieve or your stress, and then you come out, you are well relaxed, and everything is done in a good manner. So pelvic floor dysfunction, in this way, we can see there are parts which might be anteriorly or sometimes medially and posteriorly. But what is more important, all of these dysfunctions or these syndromes or these kind of symptoms in this region, all of them can, affect the quality of life. We should also understand that a lot of pelvic floor dysfunction is not coming just in one piece. Sometimes the patient has 2 or 3 different symptoms at the same time. This is why it's so important to have a global view together to understand, because these neighborhoods sometimes, the problems, the symptoms is on the bladder, but the origin of the symptoms is intra or extra pelvic. For example, neurological pain in the regions of the pelvic floor, we know there are some nerves which are integrated, interestingly, originated in the pelvic, but we have also different kind of nerves. For example, I was talking about the hypogastric nerve. This nerve is not originating from the pelvic. I can talk about the inguinal nerve. All these nerves, they are not originated from the pelvic, but the patient has symptoms inside the pelvic. So whenever we do the surgery, according to that surgery site, according to the neighborhood, anything which passes through that region can be affected. And the life also can be affected according to the symptoms. So we need to have that in mind. Another point I would like here to say that, as I was saying in the beginning, that pelvic is the center of our body. That means it is connected to different parts of our body. This is why we need to have a thoraco-abdominal pelvic floor global view, so that we can understand the dysfunction in this region, including, for example, the posture of the person, the respiratory system, the abdominal function, neurological, and so on. All of them participate to keep the balance. In my second part of my topic, I'm going to talk about the overall view of the surgeries in the pelvic area. I will try to introduce, my attempt is to introduce in a few minutes different kind of surgery. We have urogynecological, anorectal, or in the pelvic area. All of these ones are common. They are working together, or they live in the same region, the neighborhood. So this surgery, it can be urogyne or anorectal. That means from the anterior, medially, and posterior side. There are minor, moderate, and major surgeries in this region. Some of them are very simple. For example, Bartholinits, or whenever the patient has episiotomy, we call them simple. You suture it, it's over. Or you do sometimes laparoscopic when it comes, for example, extrauterine pregnancy, for example. These are minor kind of surgeries, okay? So we have also moderate surgeries, which need some challenges. Maybe in one day the patient comes and go, or whenever we need some others treatment behind that, or such kind of surgery which can integrate some complications which are minor, which is not about cancer or lymphadenectomy or radical hysterectomy. These are major surgeries. The cause of these surgeries are variable. It can be located from the disease, infections, or like we say, the pregnancies or not. That's right. And there are others which are, for example, cancer, or different kind of trauma in the regions, like a car crash, for example, accidents. These can have problems whenever it's come the perforation of the organs, for example. All of these can become, you know, the origins of pelvic surgery is variable. It's just connected to our lifestyle and the humankind. And then the major pelvic surgeries need a long follow-up. It's not just whenever we do the surgery, it's over. We remove the disease, or we fix the organs, that is over. No, we need to reconnect, to reprogram, because the surgery or the trauma itself has created some changing in the environment. This is why we need some kind of rehabilitation to bring back what the patient has lost before and during and after the surgery. The type of gynecological surgery here, as I said, there are minor ones, laparoscopic surgery, outpatients, the patient which come in the morning and late in the afternoon, they are back home. We have moderate surgery in gynecology, like a hysterectomy. It's a part of, because we have different type of hysterectomy. The simple one, transvaginal one, there is no trauma, the patients do not have any others, high risk factors. That kind of surgery can undergo and the patient can recover quickly, we can say that. And the pelvic organ prolapse as well. But we should never forget, sometimes you do well your surgery, whether it is vaginally, hysterectomy, or transabdominally, or using laparoscopic surgery. After the surgery, sometimes in the long term, these organs, because the cause of the prolapse is the deficiency of the attachment organs, the ligaments, the fascias, they are the ones which lost control, and the uterus or the anterior or posterior part of the vagina becoming prolapsed. For example, the cystocele, whenever it is the anterior vaginal wall, or hysterocele, whenever it is the uterus which comes down, or whenever it is the rectocele or anterocele. But we should never forget and keep that in mind that, yes, this patient has rectocele or hysterocele or cystocele. We should never forget that the cause of the descent of this organ is the attachments. That means the failure of the fascias and the ligaments made it possible, or we can say also the disconnection or unbalanced intra-abdominal and pelvic pressure in the long term made that organ, because of the gravity, because we stand, this is why it comes down. So if we want to treat the patients while we are doing the surgery, we should make sure so we pay attention to that question. Otherwise, after a vagina hysterectomy, or transabdominal hysterectomy, this patient can have what we call the vagina vault prolapse. That means the prolapses of the vagina dome, that means the upper part of the vagina, after you remove the uterus for 6 months or a few years later, it comes again. It's becoming the same symptoms. The patients will come to you with the same symptoms of, organ descent. So it's so important to fix the origin, not only the consequences. We need to fix the origin of the matter, not the consequences. I will give also some examples about the major gynecological pathology. Here you see, for example, when it comes to cervical cancer, we know now this disease, in 99%, it's connected to HPV, high high-risk HPV. We have a lot of high-risk HPV. For example, the 16, 18, you know, we have a 31, 33, 35, 65. All of these, we have a variety of HPV, but I'm talking about the family of high-risk, you know, HPV, which infected women. It is sexual transmitted, of course. And then we can see from the uterus cervix, this region, the patient is going to develop a kind of cancer, whether it is squamous cells or adenocarcinoma. We have different kind of histology. And whenever we have such kind of cancer, we need to remove most of the time if the patient is not very young and the disease is not located, it's just located in this region, we can remove partially. But whenever the disease reaches to a certain level, we need to have a major surgery in this region so that we can save life of this patient. Such a surgery is to save life, to remove the disease, and the patient should undergo such a surgery. But as I said before, yes, we need to save life of this patient, but also we need also to understand that the lifestyle of this patient should not start from the surgery. It has never started from the surgery, we know that, and it should never end after the surgery. That means after surgery, we still have life. This is why it's so important now to how can we work together to help these patients after surgery, whether it is prostatectomy, whether it is radical hysterectomy, how can we help these patients to regain control of and improve the quality of life? That's the question which we try to challenge in today's topic. And just to remind also, we know now in different parts around the world, especially in Europe, for example, and in different parts around the world as well, there are a lot of screening cervical cancer. I use this opportunity to say that also we need to screen. There are some vaccines which do not cover all the different kind of HPV, but they help at least to prevent some kind of, because we need to, the best way to treat this disease is to keep on doing the research, keeping on discovering different kind of vaccine. Now we know there are already 9 which have been found. Vaccine which is available in different countries according to different policies, which can help these young children. For example, in France, we know from 11 to 14 years old, a young girl can have their vaccine, and this help really to reduce, not to cover completely all the HPVs, but at least to help them to prevent such a disease so that we may not undergo such a complex treatment later on after a major surgery. So in the major surgery can be located in the uterus, for example, the cervical cancer, endometrial cancer. Disease can be also in the ovaries, fallopian tubes, vaginally, vulva, and then anal sphincters area regions. All of these can, after surgery, the patient might have scars or might have some adherences, chronic pelvic pain, or dryness in the vagina and pelvic floor dysfunctions, and affect the quality of life of this patient. The aim of surgery in the pelvic area is to remove the disease, ablation. We remove the disease. There is a cancer there, there is a mass there, it must go. So we remove it. But we should never forget this disease was in a particular site where there were a lot of organs working together. Secondly, is to try to reconstruct. That means we remove, but we try also to build. Sometimes, you know, there is abnormalities in that region. So we try to reconstruct, to bring it to close to the normal. And then sometimes we can transplant, use foreign bodies, like for example, different kind of meshes we use in pelvic regions, whether it is the TVT or the TVTO or TOT, all these surgeries, it's a foreign body, which is there to help to fix the mobility or to make sure that this patient can keep a normal function. And we have also some major surgeries in pelvic area, which is palliative, which is helping the patients to reduce the symptoms, improve the quality of life, especially whenever they have some terminal disease, which is not curable sometimes. So we help them to reduce the pain and so that they can have a close to normal quality of life. So before, if we have to compare before and after pelvic major surgeries, what changes? What is the changes after such a surgery in this region? There are different kind of changes. First of all, I will focus on the vascular system. We know our body is connected together from our heart to different parts of our body using the vascular system. From the cellular level, there is a connection. Neurological system, neuromuscular system, anatomic positions as well. We know that these organs, they work together or they live together in the neighborhood. There is some anatomic connections. we have also local tissue in that area. You will do the surgery. We have epithelium, we have subepithelium, we have conjunctive tissues. We go to the muscular. We have different range of layers of tissue together. And we should never forget the tissue. They're the ones which connect together to make the organs. And later on, we have the function. And the system is made by different functions together, as we remember. We have some local inflammatory reactions after surgery, in pre and post surgery, especially in a short time. And then we have the changes on the pathway connections to the central system. This is so important. After we do, for example, a radical prostatectomy, or after we do a radical hysterectomy, in order to remove the disease, we need to cut these ligaments farther as possible. For example, the uterosacral ligaments, we have to go close to the pelvis. This is what we call, for example, the type 3 radical hysterectomy. So while we are doing such a surgery, we know now that inside the uterosacral ligament, there are some neurological system there in the pelvis. We have sympathetic system, parasympathetic systems, and even somatic system, which passes through the uterosacral ligament. So when you remove such a ligament, because you have to remove the disease, we have to undergo such a surgery, they will be slightly too complex, impact or affections to the functions of this system, neurological system in these regions. And that can affect, for example, the quality of life when it comes to the bladder function and the bladder detrusor and the urethra, that means the micturition functions, or the anorectal dysfunction, because we know all of these sympathetic, parasympathetic, and somatic system, they work together to make sure that all of these organs and muscles around the functions in a normal range. So whenever there are stimulations, because in our body we have a kind of electricity, neurological neuromuscular stimulation is damaged. This is why some of them, after radical prostatectomy, their sexual function maybe goes down. Some of them, they have problems to defecate. Others, they have problems to urinate. All of these post-surgical complications are connected to the site of our surgery. Everything is connected together. There is now some changing. Your central, the brain tried to send a message to the pelvic area, but the message cannot reach there because there is no connection in that region after the surgery. So we need now how can we help to reconnect, or how can we help? Because it is partially damaged. The nerve is not completely damaged, because if it's completely damaged, that is almost impossible. But it is partially damaged. So there is some possibilities we can improve. Maybe it might not come exactly as normal as it used to be in a short time, but in the long term, we are able to make sure that this person regain a normal function. That means less side effects post-surgery. This is the aim of our topic. This is a challenge we have today. The tissue and the types of and their functions. As I said, we have epithelial tissue, we have connective tissue, we have muscular tissue, and nervous tissue. These tissue together, they help our organs to have normal function. On my third part of our topic, I will be talking about the overall view of pelvic floor rehabilitation. So when I will talk about this topic now, I will focus on the history. Last time I introduced the history of pelvic floor rehabilitation, especially in France, in different parts of the world. In Turkey now, people, they started. In China, I know they're doing a great job there. In different parts of the world, people work hard together to use these non-invasive techniques to help our patient to recover. So in France, for example, we have the history here. I talked about this last time. Kegel was the one who brought it. And then there is one also in France, which called Alain Broussier, who went there, who learned techniques. Later on, he brought it in France. And now it's become, for more than 35 years here in France, we have been using pelvic floor rehabilitation as a multidisciplinary approach, working together with different specialties, helping the patient in pre and post surgeries to recover. And we know that by doing so, not only there are some patients, not only they will undergo their surgery, but more importantly, they will regain control of their lives and have a normal lifestyle. It's so important to integrate that. Maybe, of course, I'm not saying pelvic floor rehabilitation is able to solve all the problems around the world. Not, but it can help to improve, to regain control, improve the quality of life. It's so important. The pelvic floor rehabilitation here use different non-invasive techniques. We have, for example, and we know now in many parts of the world, including in the guideline here in France, most of the time, it is the first line of the treatment. The first line of treatment should be non-invasive. From the history of medicine, we were taught that before we use major methods and techniques, let's start from simpler, according to the problems, to complex. Of course, there are some problems we need to do the surgery. But the question is, yes, we will go under surgery. Is it possible before such a surgery to prepare our patients so that after the surgery, this patient can get the tools? We will give them the tools by teaching them, for example, to reconnect their brain to the pelvic so that after the surgery, of course, somebody will say, of course, before surgery, they had the connection. But the problem is, if they don't know how to contract using these tools in pelvic floor rehabilitation, after the surgery, they just go there and then they start from zero, but it's not from zero, from -10. That means they will have 1 or 10 steps back before they really start to learn and to regain control. But if we pre-major surgery, we teach them how to work, they understand what they are going to do, they know how it's worked together in just a few sessions. We don't need to do a long term, 1, 2, 3, or 4 sessions. Then they will try to memorize, because we know our brain can memorize how can I do to gain such a control. And then later on, it's gonna help them to recover in the best way. So, in common techniques with manually, electrical stimulation, biofeedback techniques, using hypopressive, that means abdominal integrated to respiratory techniques to help this patient to control intra-abdominal pressure. We use the thoraco-abdominal, pelvic floor rehabilitation techniques, postural, all of these together help the physiotherapists, they were trained, they know these techniques, and they know how to use from one to another to help this patient according to their situation specifically. It is so important to understand that whenever we do these techniques, we started statically, but it's more important to use also dynamic techniques, because a human being is moving. These symptoms in the pelvic floor most of the time, it's when we cough, when we sneeze, when we jump, when we laugh, when people, they're having their sexual intercourse, they feel the pain. It is when we are moving, it means in action. So the pelvic floor rehabilitation, also these techniques should adapt themselves and treat the patient according to their normal life. This is how we can help them to control whenever they are in the street and whenever they live their normal life. So pelvic floor rehabilitation in the manual treatment. I will try to introduce a little bit what is manual treatment. Of course, it's the first step of the assessment of the treatment session. Also, the manual assessment creates a link, a connection between the patient and the physiotherapist. It's so important in medicine, we learn whether it is gynecologist, urologist, gastroenterologist, any specialties. The clinical examination is the most efficient part. We often have a 50 to more than 50% of the right diagnosis of the patient whenever just we ask the questions, the history taking, and then whenever we do our clinical exam. And the clinical exam is made manually using our hands, our eyes. How do we hear? How do we see the reaction of the patient? So whenever we ask the history taking, the patient will tell us, for example, when I cough, when I sneeze, I have link of urine. I start now to connect, okay, what could be the cause of the link of the urine when the patient is coughing? Oh, the intra-abdominal pressure increase, okay. But why in such particular moment, the patient have link of urine? Then I will go, maybe, the pelvic floor muscles are not working, the reflexes are not there, the organ is not in a normal position, they are hypermobility of the urethra. So I go deeply, I started to think about it. Now, when I go to the clinical, according to my hypothesis, whether it is deficiency of the sphincter in the pelvic area, the muscles, whether it is the hypermobility of the urethra or the, the range or the ratio between intra-abdomen pressure, that means the bladder and the urethra is imbalanced. And then I have the diagnosis according to my clinical. And this clinical, most of the time, is manually, or we use our eyes. This is what I say here. It's so important to use sometimes our hands, whether it is during our assessment, but as well during our treatment. We use manual for helping the patient to regain the, the prior, proprioceptive sensations, because we have neurological connections there. We have some receptors. We have the feeling. The patient can feel you are touching in the spatial part, and you ask the patient to contract spatially so that according to the task you are asking, the patient will use the brain connecting the motor center to try to contract efficiently so that she can regain, for example, the pre-contraction reflex, for example. It can help to strengthen the pelvic floor muscles. It can help, for example, manually to relieve the pain for those patients who are having, for example, the hypertonic or neurological pelvic nerves entrapments. So we use manually to go there to try to relieve the pain by doing the massage, for example. We use also manual to help the patient to relax. If you have the muscles which is hypertonic, whenever you pull it again and again, later on the muscle will relax. So we use these techniques to stretch these muscles so that they can relax whenever it is necessary and regain their normal function. And then we can add some postural, respiratory, hypopressive techniques to help this patient regain. So manually, it's so important. But we know also manually is a kind of I call it semi-dynamic. It's not 100% dynamic because a human being can run and jump. How can we use manually while the patient is running and jumping? Because we need to adapt our treatment according to the lifestyle, right? So we need other tools which can help us to really put our patient at the real situation, normal life, so that when the patient has a challenging of linking of urine, for example, while coughing or sneezing or jumping, we put the patient in the situation, we ask the patient to run and to jump, and we try to look what's happening inside using, for example, biofeedback technique. Later on, I will talk about it. And the advantages about the manual treatment is easy access. We got our hands, we just go and feel, and then try to reconnect with the patient. We create some, direct connection with our patients, and it provides as well the multiple possibilities to help the patient, whether to relieve the pain, strengthen the muscle, bringing back the proper, the proprioceptive sensation and the feeling. So manually, it's so important, we need it, but it's not the only tool. It's help us to do some of the things, but not all the things. It's inconvenience or the limit, we can say it is not directed. It does not give us a direct feedback. That means we use manually, but yes, as a physiotherapist, when I put my finger there, I can feel how the patient is contracting. But can the patient really feel and quantify how much is she contracting? Is so difficult for her to really quantify it. So the feedback is limited. Another thing here is subjective to the therapist. It's depending on how much resistance I, as a doctor or a physiotherapist, I put my finger there. How much resistance I put. For example, me, I put an XF force or resistance. The other therapist is different to mine. So me, I will say maybe her pelvic is weaker, but she will say it's not so bad. So you see manually here, we have different kind of assessment. The result is not uniform. We have different results according to different experts and according to their experience. More we gain experience doing clinical exam, better or close we will be to close to the reality of the patients. And then, of course, dynamically, as I said, we cannot put our finger there and ask the patient to run and follow the patient behind. It's not possible. I don't know who can do that. That's right. So we need to find ways. How can we not putting our finger, but the extension of our finger? This is what I call the 6 finger of the physiotherapist on my way of saying that we need to find ways using other technology to help us to combine manual and others so that we understand how the patient is performing while she or he is running or jumping. What I'm talking here is not only about adults. I'm talking also about children, any human being, whether it is male or female, because we know pediatrics also. These children, they have symptoms in the pelvic area. They can undergo surgeries as well. So these children, if after a major trauma or surgery, we do not help them to regain control in a long term, it's gonna be the handicap in their life. It's gonna affect really poorly the quality of life they will have in the future. So the application of electrical stimulation and biofeedback techniques, now I'm going to try to give you a little bit clue of the sixth finger or the sixth sense of the physiotherapist, I can call it, or the combination of the technology and what we have today in our techniques and our experience, which can help us to help in a better way our patients in a good manner. So the place of instrumental pelvic floor rehabilitation. The instrumental pelvic floor rehabilitation is just an extension, this is what I was talking about, of the physiotherapist's hand. It cannot replace, it is a combination. That means we have the physiotherapist, but the physiotherapist is using tools the same way as a surgeon. When the surgeon goes to do the operation, we need a scalpel. Whether it is electrical or whether it is classic one, we need a scalpel. Sometimes we need to do laparoscopic surgery. Our eyes, cannot see further. We need to zoom. This is why we develop, mini invasive surgery. We need all of these tools. Medicine is developing. We need to follow and try to help. More importantly, we need to think, how can we use these tools in the best way so that it can help our patients regain control? The question is there. It's not our comfort. It's not because we do not want to run with our fingers behind the patient so that we are lazy. It's not that the question. The question is, how can we understand whenever this patient is jumping, what's happening really inside? How the different pressure, how do the reflexes, do they react at the right particular moment? That's the question. It provides different tools, whether it is electrical stimulation in a passive way, whether it is biofeedback or postural technique combined with these techniques help us to have the reality on time, especially, and to understand what is happening at that particular moment immediately. So electrical stimulation, the principle of electrical stimulation, we use the signal, electrical signal, which we use the milliampere. This is the amount of the current we use. And then we have the frequencies, different frequencies, how many phases, how many cycles in 1 second. That's what the frequency by definitions. And then we will try to see the wild of pulse in multi-second. So we have different parameters working together to try to understand how this patient, or in which part are we working, are we going to stimulate? We will choose according to the specificity of the fiber muscles. The objective of electrical stimulation is to waking up the proprioceptives and the reinforcing the pelvic command using passive channels, analgesic treatment for the ones who have pain. We can use TENS, we can drain using electrical stimulation, another kind of current, which is completely different to the biphasic, rectangular, the one I was using for reinforcing, or the one I was using for treating the pain. Here I'm using a drain kind of current, which is is not in a microvolt, but we use a millivolt, milliseconds. I'm talking about the wild of pulse. Instead of being, the timing there is completely different. The shape of the current is completely different. It helps these smooth muscles, especially because we are talking about drain. It's the lymphatic system or vascular system. It can help them to pump and increase, the flow, the blood flow, so that we can, those who have edema or post-traumatic or post-surgery, for them to cover in the best way, especially those scars. Okay, we help to increase the local vascularization so that it can reduce as well. We know it can reduce the adherences among the layers and the tissues, so that this scar can be flexible and can be just whenever you touch it. Even when you see there is a scar, but when you touch with your fingers, it's just exactly as a normal part, which has never been under surgery. But if the scar is not recovering in a very good way, sometimes we have the adherences, and that is not good, not only for the reflexes, but sometimes it can create different kind of pain. So we need to use all of these techniques to help us. We have another kind of current, we call it interferential currents, which help us in the pelvic area especially to treat in the deep, because the frequency we use here is higher. It's not about 200, 600 or 700. It's about, it can go to 2000 hertz. So we can see, so that it can go deeper in the pelvic. So we use different kind of currents to help us to have different functions in different kind of organs, to help them to recover in post-surgical treatment or post-traumatic. Here I give you this table to show you these different kind of currents, especially the one we use to reinforce or for pain relief. We have different kind of fiber muscles. We have this one we call the tonic fibers or type 1. We have the 2A, we call it semi-phasic, and we have the pure phasic, these fiber muscles in our pelvic. I'm talking about the deep pelvic floor and superficial pelvic floor muscles, whether it is a pivovagina, pivorectalis, pivococcygis, iliococcygis, and ixococcygis, or in the superficially, when I'm talking about, for example, the bulbosponges, transversal pelvic muscles, and then we have the ixocavernous or the anal sphincters. These ones are superficial. So we know in the deep pelvic floor, the majority of them, the majority of these muscles in deep pelvic floor, they are tonic. That means the type 1 type here, more than 70 to 90% of them. And we know in the superficial pelvic floor, the majority, they are phasic, pure phasic, more than 90 to 70 to 90% they're phasic. That means there is only a small minority of the tonic in superficial pelvic floor. And the same way, we have a small minority in the deep pelvic floor compared to type 1. And we can see these type 1, for example, their frequency is about 8 hertz to 33 hertz. And the wild of pulse is about 320 to 740 microsecond. You see, these are the kind of frequency and wild of pulse we can use here. The same way in the 2A, the intermediate ones, we have, these are the frequencies and these are the wild of pulse. And the same way, in the same manner, the 2B, these are the frequency and wild of pulse. This is why I put it here to just to sum up so that people can see the different kind of fiber muscles, so we can target, we can choose different kind of currents to target those ones which were affected by the trauma after our assessment. Also, I would like us to show you that the type 1 fiber muscles, in majority, they are oxidative. They are the ones who got a good endurance. Their oxygens, the energy comes from the oxygen. And we can see here, it's about the glycolytic. The glycolytic, that means the sugar. I'm talking about the sugar here. You can see different kind of energy, different kind of fiber muscles use different kind of energy. This is why we adapt our training when it comes to time of rest and work. The ratio together is different compared to the type of the muscles, fiber muscles we target for the treatment. We use different kind of tools to pass the electrical stimulation. We have, for example, the external electrodes, the vagina probes. As you can see, we have different, or some of them, they are in metallic here for the currents, but we have also the pressure probes. You can see, we use them to get the pressure, the contraction into the vagina area. We have also a very interesting, I will introduce to you, we call the Doigtier probe, which I will introduce later, especially. We put it on our finger and send electrical stimulation. For example, the patient who have deep pelvic floor pain, I can use such kind of probe. I wear it on my finger with my gloves, of course, and then I can go to the particular area in the deep pelvic floor and send electrical stimulation. I personally use that in my clinics. I have a lot of patients in postpartum or after surgery, or anyone who have a deep dyspareunia or deep pelvic floor pain, after any kind, whether it is surgery or not. And then if I found that they have hypertonic, I can use the current to relax it. I can drain using electrical stimulation. I can do the massage together with my finger, massage combined with electrical stimulation, and the result is unbelievable, because most of the time, this region in this area, the treatment we have, we do not even have surgery treatment. The surgery we used to do in that region, most of the time we use infiltration. And we know in the long term, we cannot just keeping on infiltrating these patients. It does not work like that. And in the long term, these patients really, their life, quality of life, we know that it's complex. there are no tablets which can solve this problem if we don't go there, especially in the origin, and try to help them by removing such a pain. I will be talking about it later on. Here we can see the different kind of vagina probe. We use the classic one in different part of the world. This one, I put it here just to show you that even these vagina probes, sometimes we can choose. You see here we have 4 electrodes in this vagina probe. For example, we have sometimes asymmetry left and right. We know it. If you assess the left pelvic, deep pelvic floor and right deep pelvic floor, you ask your patient to contract. Sometimes the contraction, the quality of the contraction is not the same from the left to the right. So sometimes now I can use different kind of electrical stimulation. Here I put higher because it was too weaker, and here I put medium, so that to try to, to help this patient to keep the balance and to control efficiently in both two sides. So by using such probes, we can selectively increase more intensity or increase the wild of pulse from the right area compared to the left. Sorry. So we can see these things can help us, to be precise or close to the reality and helping this patient to regain control. Because here we are talking about controlling and contraction efficiently, relaxing efficiently in the same manner. It's not only about contraction, but sometimes we need to relax as well. So we can adapt according to what we need, if it's to contract or if it's to relax, left and right asymmetry. So we use the perisize, we call it vagina probe. It's very common here in France, and I think in the near future, or maybe you have it already in different parts around the world, we are using that. Here I show you the picture also. We see, because different patients do not have the same conditions. The size is not the same. The shape is not the same. This is why you can see here we have varieties of different types of probes used in pelvic floor rehabilitation. Well, some of them, they're smaller, other one a little bigger, larger, wider. But we should understand there is no ideal probes for universal for all the humankind. No, it's not possible. We are different. It's different from one person to the other. This is why we have different shape and different size. What is more important here is whether it is a doctor or the physiotherapist who is doing such a treatment, to adapt and to have the best tool close to the reality of the patient, which can help. In the same way, when we do the surgery, we use different tools, different size, according to the complexity of the surgery we are going to do. We need to have a good exposure. So if we need to have a good exposure, we need to have, different kind of forceps and others, which can help us, so that we can have a good procedure during such a surgery. So in the same manner, the physiotherapists, they need also different kind of tools which can help them, to be close to the reality. Some of them, of course, they are used to work with some of the tools. Yes, and it's important also to use the tool, the one you feel the best. But we should think first patient before we think about the comfort of the physiotherapist or the doctors as well. Vagina probe, we use that, as I said, also. What is electrical stimulation? The principle is so simple. In the pelvic, you have electrical stimulation, as you can see here. It goes in this way, and then contract these muscles, the signal goes, and the person contract by using voluntarily or passively using electrical stimulation. We can feel that, oh, something is moving there. So I got the signal because of electrical stimulation. I did not contract, the current went there, I feel something is moving, I got the signal. So we can see there is a connection between the pelvic and our brain. I can also voluntarily, whenever the current comes voluntarily, I contract with the current. So you see, we have different ways of doing, but all of this is just to help us to do one thing: reconnect our pelvic to our brain and regain control. That means to have efficient contraction whenever it's necessary, or efficient relaxation whenever it is necessary as well. We see different ways of helping this patient. So we use also these probes, whether it is vaginally or rectally, whether it is male or female, but we avoid using such a things for the children in pediatrics. In pediatrics, we often use what? External electrode, because it is invasive. We call non-invasive, but actually it's still invasive, especially for children. So we avoid using such a thing. Biofeedback techniques. So the technique of biofeedback, what is that? We use the EMG signal, helping us to understand or to have the picture of how does the patient contract inside. The feedback, the EMG, we goes through the device, it's got the processed, and then send it to the screen, and then we understand. We, when I say we, I mean the patients and the doctor or the physiotherapist, they understand what is going on, what's going on. How does the patient relax or control? And we can help the patient to shape some kind of exercises according to their conditions. The objective of biofeedback here is to reinforce the pelvic floor command. When I talk about reinforce pelvic floor command, I mean that when it comes to motor command, that's right, we decide not to push the gas, or we decide to control, not to pee. That is our command. We have the possibility to do that. Some of our patients cannot. Whenever they cough, they sneeze, things are out. So we need to help them to regain control. We have different way of doing that. By using the biofeedback, they will see how do they operate and what's going on in the pelvic. And then we will try to adapt to different kind of exercise, use a different kind of difficulties. I'm talking about the shape of the curve according to the patient's difficulties. Then thereafter, we are going to do different kind of exercises, reinforcing or relaxing. Whenever we talk about relaxation here, I mean negative biofeedback. Negative biofeedback is for relaxation. The patient here has hypertony. You want the patient to know that what's happening inside is hypertony. So she will learn now, because she can see on the screen it's too high, how to let it go down. So she's learning how to relax. Here, the picture just tells us this muscle, whether it's contract or relax. I can see it on my screen. We should never forget one thing very important. Our hands or our face, our lips are well developed neurologically, sensitively with the receptors, and the control in our brain. They have much surface compared to our pelvic area. You can see this gentleman here is too small, but you can see the lips, the tongue, you can see the hand is more developed compared. It means this helps us to understand why some of our patients clinically, they come to see us with some pain, but when you ask them, where do you feel the pain? It's so difficult for them to tell you where. They know it's somewhere there in that region, but they don't know exactly where perfectly. Sometimes you do the ultrasound, you do different kind of complementary assessment, and you cannot even get the real result, because it's about functioning. It's about muscles tension. It's about the nerve entrapment. It's about the vascular systems abnormalities in that region created the inflammatory reaction, and these patients for longer on and on, especially in dynamic, when she's walking, when she has her intercourse, or when she's peeing, or when she's pooing. All of these made this patient in a very uncomfortable situation, and the patient feels the pain. The patient knows the pain. The patient has memorized the pain, but the patient cannot tell you exactly where she feels the pain. This helps us to understand it. We cannot blame the patient why they're not helping us. It's because naturally our pelvic is not well developed when it comes to the sensitive and particularly connections to our brain. Since we understand that, you can see how complex the topic is, how difficult sometimes to have the right diagnosis. And more importantly, there are a lot of neurological nerves and branches passes through the pelvic, but they are not originating from the pelvic. I gave you already some examples. Even I can even repeat them. When it's come from the inguinal nerve, for example, you know, the hypogastric nerve, you know, all of these nerves are not originating from the pelvic area, but they originated from T10, L2, but they come through the pelvic. We have different kind of the muscles as well, like the psoas muscles. These muscles come from the almost T12, L1, L2, but passes through the anterior iliac and goes through inside the pelvic and reconnected even to our lower limb, to see how the pelvic center is the station of the passing channels of different organs and then creating sometimes some symptoms in the region. This is why we use such a way to help the patient to understand how she performs using biofeedback. We instruct the patients how to contract or not. We exercise using statical position or using dynamic position. And then later on, we will analyze the result comparing from the first time she came and to the last time. This video, actually, I have already shown you. For those who came here last time, you can see biofeedback is the patient contract. We have the vagina probe there. The vagina probe catch the EMG signal. It goes to the screen, and then we can see how does this patient is contracting and relaxing. It's helping us to understand what is really going on. It could be not only the origin of the symptom from the pelvic, but most importantly, how does she perform? We get it on the screen. We use different kind of pod. This is the one we use, for example. I use this personally, and then we use it because this is wireless technology. It's helping us. You remember what I said, it's so difficult to put our finger and follow the patient dynamically. So this is why the people, they work so hard, they develop some wireless technology, helping us to use electrical stimulation. This one helping us to use the pressure probe, having exactly at the same time, at the right time, what's happening, the biofeedback curve, and we understand how the patient is performing. So wireless technology is really changed a lot when it's come to the way we treat our patient, even to how we understand the matters in the pelvic area. So we use also some kind of probes. This one, for example, sorry, on my right area, we use it for electrical stimulation and biofeedback. We can see the signal on top. And the one here on the left, actually, it helps us to record some kind of electrical stimulation. I can give it to the patient to go home. I have some program inside, and then the patient can use, for example, whether it is vagina probe or external electrode. She can go home, go with this pod at home. The program is there. She set it, she connected, and she has the treatment if it's once a day or twice a day. So you can see, for example, the patients who have overactive bladder. This patient, instead of just taking the drugs every day, and these drugs, we know sometimes in some patients, they have some side effects. So we can use, for example, posterior tibial nerves stimulation or vaginally to inhibit the bladder death result. We use such a pod. We ask the patient, we call them the pod, to go home and to do it. I program it. I use low frequency like 5 Hertz. I use the wild of pulse up to 400 millisecond, and then I ask the patient to go and to do such exercises once a day or twice a day, for example. So this is to show how we can help these patients when especially we have a lot of patients together. It's so difficult to give every patient at the right time. This technology is helping us to do, such kind of treatment, whether it is inside the cabinet and controlling and guided by a well-trained physiotherapist, or whether you have a follow-up with your patients. They will come twice a week, for example, and so on. The advantages of these things, as you can see, the extensions of such a treatment, helping the patient to contract, to control their comment, but also to have the possibilities to work with a different range of possibilities and helping this patient in a passive ways using electrical stimulation or biofeedback techniques. Pelvic floor rehabilitation in pre-surgical treatment. This is a hot topic. Some questions that people ask, is it really important or necessary to ask the patient to undergo the pre-surgical treatment? Here, I tried to focus and show you the benefits or what is important when we do and how we do it. First, what is the aim of the pre-surgical pelvic floor rehabilitation, actually? It is about programming a patient to the post-surgical recovery. Remember, this patient will undergo a major surgery, and we know most of this major surgery will come out with some complications, that's right? Or we can call it the side effect, or we can call it post-surgical complications, okay? So, but these patients, they need to have a normal quality of life. Now, how are we going to help them to program the best recovery as possible? It is about explaining to the patients what kind of treatment the patient is gonna face after surgery. It is about also informing the patient on how to better control the symptoms and how to improve fast the quality of life after surgery. And also, it is about creating a sensorial and memory. This is so important. I am not treating something there when the patient comes pre-surgery. Maybe she has not incontinence. She only has pain or a kind of tumor. She will undergo surgery. So me, when I do electrical stimulation in that region, The patient will feel how does electrical stimulation feel, we felt. And then the patient will memorize the feeling of electrical stimulation inside the pelvic. This is very important. If you have never felt anything, how can you imagine about that thing? It's impossible. Our life is made with experience in our lifetime. Our lifetime is made with experience. We have good or bad experience, but we are learning through our experience in our lives. Electrical stimulation for this patient at that particular moment is exactly just like our lifestyle. It will create some memory. It's remind the patient, oh, you should contract like that. This is the way you should do it. It's so important, and this patient can figure out how to control the command in post-surgical period. That's it. It's so important. It's about creating the connection between the physiotherapist and the patient. Of course, this physiotherapist and the patient, they will work as a team. If you try, I trust you, you trust me, you are here to help me, but I need you to help yourself. You know, such communication is very important because they will work together as a team, not as only two, but with multidisciplinary approach with the surgeon together. The surgeon will tell the patient what kind of surgery is she's gonna go or he gonna go, what kind of complication it might happen after surgery. But I need you to understand it. We will need some treatment after surgery. It's not I wait until the symptoms occur, then it becomes too late. It becomes too late because there will be no memory there. There will be no feeling. The patient comes there, she or he has changed after surgery because things have changed in that particular region. The patient thought he remained the same. The patient will keep on controlling in the same way, but the area has changed after surgery. It is about planning the treatment procedure at the optimal time for a better outcome. We don't wait too long, too late. It is about a specific treatment planning for the individual patient. That means I will look to the patients according to the patient's type of surgery and trauma he or she will go. And then I will try to think about what kind of complication most of the time they occur. I will give treatment planning, explaining how we're gonna work. I will make the patient feel what is electrical stimulation, the pelvic. Sorry. What is the electrical stimulation in the pelvic area? What kind of feeling is there? And more importantly, I will use also biofeedback so that the patient can see how the curve, how he or she can contract. Because such a vision way of biofeedback can help the patient to reinforce the memory of the contraction of the pelvic. It is about how to improve the quality of life for a patient who will undergo a major surgery. When I was preparing this PowerPoint, especially the slide, sorry, the slide I have just shown you there, something came into my mind immediately. He said, come on, what I'm talking, how can I make it simple so that people can understand? So I had this sentence which came to my mind. The sentence says, a blind man with his stick will find it hard to follow a new path for the first time, but he will easily find his way if he has used that path before he becomes blind. What does it mean? Imagine this person will undergo a surgery, huge surgery after prostatic cancer or cervical cancer, for example, or colorectal cancer. Such a surgery, as we learned previously, as we have talked, they may affect neurological function, tissue, and so on. That's right. The region is going to change. That's right. Everybody is following me here. So the patient go inside the operating room with all the organs and function almost close to the normal, regardless to the cancer or the trauma. But this patient will come out of the operating room as a new person because something has changed in the pelvic. After we remove the disease to save the life of this patient, for example, there are some damage of the branches in that region. So remember, you go in the operating room, you come out, you are blind. So that if before you go to the operating room, you have never learned how to contract and what means contraction efficiently, how do you want to know how to contract in the very easy way, since you have never experienced it? So a blind man, most of them, they walk alone in the street. They have their sick, but imagine you take the blind man from your country in that neighborhood, you put him in another region without telling him what is around. It's gonna be a challenge. Just from in the same city, you change the corner, you put him in another district. It's gonna be difficult. He's going to struggle. Maybe he will find his way, but it's gonna be very hard. Just what is a pre-surgical pelvic floor rehabilitation is important for the patients before surgery. It's exactly as a blind man, a blind man who before becoming blind used to have a full control. I give you another example. The bicycles, most of us learn how to ride a bicycle, that's right? You learn it more maybe when you were very young, 10 years old, 6, 4, 5, okay? You master it, but it has been for so long you never ride it. But whenever they give you the bike after 20 years later, you will ride it. You will ride a bicycle. How do you know and how do you remember after 20 years you never even ride it? Because you learned and you kept that memory. But somebody who has never ride a bicycle, young or old, you put him there, they will fall down. That's it. We learn how not to fall down by riding the bicycle, and then when we master it, we memorize that signal and the stability. Pelvic floor is just the same. It's just the same. Everything is under control and under connections. So we need to help this patient to control by giving them such kind of sensation and memories. How do we do it now? How should we work in a pre-surgical pelvic floor rehabilitation? Remember, it's not just to strengthen the muscles there, contract, relax. That is a game. It's not about that. Few days or few weeks before surgery, the patient comes. We need few sessions. We don't need 20, 2 or 3 or 4 sessions. That's all. Each session 30 minutes. The first session is most important because you will explain what are you gonna do. You will try to learn about your patients. You try to connect from doctor to the patient or physiotherapist to the patient. We'll try to connect to learn who is who and how do we work together as a team. Then we take some time to explain to the patient about the pelvic floor rehabilitation, because this topic is a kind of taboo or unknown. Some people have never heard about it. We cannot just take the vagina probe and show them, oh, I will use it, they will run. They will say, you are a witch doctor, or you are a witch physiotherapist. I had an experience in some countries, if you approach the patients without preparing your speech, sometimes the patient, they will never come back again. So it's not to frighten our patient, but it's to help them. So we need to talk slowly according to our patients, understanding according to our region, according to our culture. I know this region is taboo. This is another difficulty we need to overcome. Maybe we need a few sessions before the patient starts to understand what we're gonna do. In some places, we need more than 2. It's normal. It's not about the number here. For me, the number 2, 3, 4, that is not the meaning. The most important is the patient has to understand. Such a procedure will help me after a major surgery to regain control and to improve my quality of life. Second, the patient needs to understand, how are we gonna work? Electrical stimulation, what is that? How does it work? What is the feeling? For example, I can put electrodes on the hands of the patient. Oh, the patient will feel, oh, it's just like that, these patches, electrode. It's not something painful. And then I can go inside and try to do better. That's right. Sorry. Then also I can use some kind of biofeedback techniques to help the patients understand what's going on. I will put the biofeedback there to show the patient. Remember the picture I show you, our pelvic floor is not well developed neurologically and sensitively compared to our hands, our fingers, our face. To remember that, I talk about it just to show you that we need to put the biofeedback so that the patient can try to understand how does his or her pelvic floor is working. So we need such kind of electrical stimulation or biofeedback techniques to help more importantly, in this way, every patient will feel that we care about them. They will gain confidence among us. We will work together as a team, not only as a physiotherapist and the patient, but also in a multidisciplinary approach with communication to the doctor, surgeon, who is gonna do the operation. I saw you patient, blah, blah, blah. She came to me before her surgery. I explained to her how to do, or the surgeon sent the doctor, these patients to the physiotherapist in the neighborhood. Okay, I'm gonna do this radical prostatectomy, for example, or radical hysterectomy because this patient has a cancer. I wanna do you guys to explain to her how you're gonna do the treatment. Of course, because it's a kind of a cancer and it's a metastatic cancer. Before the surgery, maybe I'm not going to use electrical stimulation, but I can use biofeedback because the biofeedback is just asking the patient contract and relax, and the patient can see how she contracts and relax. You see, all of this is just about to communicate together, working in a multidisciplinary approach. The patient is in the center, in the middle, and we try to join our hands together using our abilities, our knowledge, our techniques, our technologies, and our techniques we use to help this patient to improve his or her quality of life. And then later on here, I will talk about the changes after pelvic surgery, and then we will finish later in a couple of minutes, and then I will answer all your questions. If you don't mind, I can keep on continuing. I'm asking the monitor, what do you think? Is it tough there, or can I continue? And then I finish, and then I will answer later on.
Yeah, we have time. There is no time limitation, but of course, after you finish it, we can ask the questions.
Exactly.
And then you can answer.
Yes, I remind people, if you have questions, what I'm talking about, please put the question on Q&A sessions, so that after that you can write it in Turkish if it's too complicated for you in English.
I can translate it, no problem.
Somebody will translate for me, and those who are in China, they can write it in Chinese. It's not a problem.
Yeah, you know Chinese.
Myself, yeah. But they can write it also in French and in English, so we have possibilities using different languages. Why not to share the same topic together? Thank you very much, but I'm not going, I understand it's not easy for people there to stay there for so long. The COVID has made it in this way. I prefer to be there, you know, physically.
Yeah, completed 2 hours finally.
But now virtually we are together as well, sharing our opinion. Not too long, I will just finish. Here I show, for example, the key changes post-surgery. You see now this patient is gonna go under surgery. What changed after that? Vascular system damage will affect a local tissue functions, adherences and so on. Local muscular systems might be damaged by such a surgery because we need to save life. That surgery, it was important. The contractility of the muscle, the strength, the reflexes may disappear. We have 2 reflexes, very important when it's come to muscles in the pelvic area, the myotatic reflex and the pre-contraction reflex. We might have also the peripheral nerves, tissue damage as well. Here we have its nerve receptors and their functions. That means they are not working, the alpha and the beta when it comes to the sympathetic system, and when it comes to parasympathetic system, we have the M2 receptors might not work properly. We have some efferent and afferent pathways which can be also affected. That means connected to our brain and to our control. That's right, the motor command can be affected as well. The sensorial centers, especially in the pelvic floor, we talk about the pineal nerve, for example, which is sensitive and motor, it can be affected as well. The autonomous system, whether it is parasympathetic and sympathetic system, can be as well affected as well. The central command will change after such a major surgery, and it's going to be dysfunctional, we can say that, and later on, even sometimes anatomically, the changes, all of these can affect the quality or the functions of the organs inside the pelvic area. After radical, I will give you some example. For example, radical hysterectomy for the women. Gynecolojcal is a very well-known surgery, especially when we treat the tumor. Absence of the uterus will change the dynamic in that regions, the surgical trauma in that regions, and the impact of the attachment of the organs. Remember, when we remove the uterosacral ligaments, the cardinal ligaments, the round ligaments, and then the fascias between the bladder and the uterus and the rectum, all there is a dynamic changings, and the vagina wall, anterior to posterior, all of them after surgery. You see there is something which has changed there. The deep and superficial pelvic floor also can be affected. The nerves in that regions will be affected as well, especially when we do the type 3 radical hysterectomy. When we cut the uterosacral ligaments, you can see here from the back, especially back, we have cardinal and the uterosacral ligament. These ligaments will, inside those ligaments, we have some sympathetic and parasympathetic systems will be affected as well. Later on, these patients can have a sexual dysfunction, pain, or so on. Some of them will have dyspareunia. Others, they will have a vascular system like the lymphedema. After lymphadenectomy of such a surgery, we need to remove all the pathway this disease might go. After a lymphadenectomy, you know, the liquid in the lymphatic systems do not have their channels. They will create an inflammatory reaction in that region. Plus the surgery, there will be some adherences between the different fascias. All of these will change the dynamic changing in the neighborhood of the pelvic area. And then we will have also some of the patients will have symptoms when it comes to the vagina, dryness, pain, especially if they undergo some complementary treatment after such a radical type 2 radical hysterectomy, for example, chemotherapy, radiotherapy, external beam, or internal. All of these will affect the pH of the vagina, infections, pain, dryness, and so on. If you add on top the age of the patients after post-menopause, you now have a clear picture that really the life of this patient is going to change if really we do not help. Radical hysterectomy, when it comes to the gynecological functional changes, we know also it can affect as well the sensation of the bladder. I used to take care of the patients, especially treated by the team where I used to work in Sun Yat-sen Memorial Hospital in Guangzhou, especially. We used to have a lot of patient cases of cervical cancer. My professors used to do a lot of Professor Lin Zhongqiu. I use another opportunity just to remind that we use them in different teams around the world. You know, when they do such a surgery, some of the patients, you will find that in post-surgical period, they will have difficulties for them to, you know, to empty their bladder. They will have, you know, but our surgery, it seems like it was not directly to the bladder. Why do they have this? Oh, later on we understood. When we do the radical hysterectomy type 2, inside the uterosacral ligaments and in the pelvic area, we have different branches of nerves which goes and connected to the bladder and the receptors, parasympathetic, sympathetic system, and all of this will affect in post-surgery. This is why some patients, if we do not help them earlier, some of them may have difficulties to regain a normal function. They may have overflow or incontinence later on, mid-urethral sphincters deficiencies and functions will be poor muscle contraction, the weakness of the pelvic floor muscles. Later on, this patient will develop different kind of symptoms, including the reflexes. For example, the A3 reflex of Mahoney is the one we use very common to reinforce the pre-contraction reflex. That each time we are, for example, driving our car in the street, we feel we want to pee, but there is no toilet. How do we do it? We control it. How do we control it? We contract our pelvic floor. 5 minutes later, we don't have any feeling that we want to go to void. That's right. In such a manner, we are using actually the A3 reflex of Mahoney. But imagine now if this patient underwent such a surgery, major surgery, this region has changed already. And later on, this patient now, she cannot control efficiently to control the sensation. Some of them, they will develop frequency, pollakiria. They will go very often, urgency. They will develop the urgency to go to pee very often. All of this because the weakness of the A3 reflex or the weakness of the pelvic floor muscles, which cannot inhibit the parasympathetic stimulation on the bladder detrusor, and then they have to go with a little amount of urine inside the bladder. They must run and go to the toilet. So we understand now all of these mechanisms are also connected and sometimes can be affected after a major surgery. Some of them will develop the hypo or hyperactive bladder or some symptoms of overactive bladder as well. Or behavior will change for this patient, and later on, if we don't help them, really it's a turning 180 degree in their lifestyle. I will also introduce, when it's come to radical prostatectomy in that region, the same things I said for the radical hysterectomy can be applied also to the radical prostatectomy with the slight differences. This major surgery is occurring at the bladder neck area region, very, very close to the bladder neck, very close to the mid-urethral pelvic floor muscles, very close, that means to the control of the urethral pressure. So this imbalance in that region will create exactly such a complex where the patient sometimes will have incontinence, others they will have difficulties to pee, others they will have sexual dysfunctions, because the sympathetic and the parasympathetic, they participate as well in the sexual life. So in the somatic, it's the motor neuron with the pinodal nerve in these regions also is affected. Sensually, we don't feel we want to pee, but our bladder has already 500 cc, but we have no feeling. Or whenever we go to pee, we have post-void residual. All of these changes can occur during a major. And the men, especially sexual, as you can see here, is one of the chief complaints, and especially their functions when it's come to urinate as well, they will come after such a surgery. We should never forget that these regions is also a part of anorectal regions. The same way, major surgery like a colectomy or ileostomy, all of these can affect the dysfunction in the anorectal area. Anatomical changes, the change in the chronology of different reflexes in anorectal functions can occur. The filling reservoir and the capacity of the rectum, the ampulla, will change, the anorectal dysfunction, and then the patient can develop some constipation, or later on they will develop a kind of incontinence. It's depending on their situation, on how the operation touch in that region, and how do they respond to such a major surgery. So we need to help them to recover by training them to regain the normal function, because this region is not exactly how it used to be before. And abdominal and the pelvic adherences may occur, can create also some instabilities when it's come to the coordination between the organs, chronic pelvic pain for some of them, psychological stress. We should never forget that it can occur to any kind of major surgery, because the patient will feel herself like she's not the same. This is why it's so important. It's so important to, during the pre-major surgery, to inform the patients on the challenging which will come, so that the patient will be prepared, I can say that. Because when you know what's happening, at least you are well prepared. But if suddenly your life turn around, it can create sometimes a shock, and that can be an impact and difficult, challenging when it comes to how to help them regain control to their lives. And the quality of life, of course, is so important. I use few articles here just to share with you the clinical management of bowel dysfunction after lower anterior resection of the rectum. In this article, actually, they explain also the American Cancer Society of estimated just with this number, very, very high number in that area in 2015. And surgery is primarily the treatment of rectal cancer, with the majority of the patients undergoing the sphincter preservation surgery with the anterior resections. But we see, although the lower anterior resections can prevent the patient from having a permanent colostomy, the bowel dysfunction may occur in 60 to 90%. This is very, very high. 60 to 90% of the patient will develop some kind of dysfunction. This is why it's so important for us to learn about it and how to help this patient after such a surgery to regain control. This one also, they use the effect of the biofeedback therapy on anorectal dysfunction after the resection of the temporary stoma. When administered during the temporary stoma, the period of the rectal cancer, the patient with the sphincter saving surgery. Whenever you have time, please feel free to go to read such a report. What here I put here, actually, it's exactly what I've been talking. Male and female, MF, male and female, different kind of dysfunction might occur after a major surgery. I summarize it in this way. What I will say here also, any major abdominal or pelvic surgery for children could also affect the pelvic floor or the pelvic area dysfunction for children as well. It's not only about the adults. Children are also inside in this puzzle. The pelvic floor rehabilitation in post-surgical treatment. Now I will talk about how do we treat them after such a major surgery. The aim of post-operative pelvic floor rehabilitation is to help the patient to, first, to help this patient to recover in the best way and in the fast manner. Improve their quality of the tissue. That means because the tissue got some damage after such a surgery. Programming different kind of reflexes. I'm talking about pelvic floor reflexes, muscles reflexes. Reinforcing the pelvic command. I'm talking about our brain to control to our pelvic area. To strengthen that command, those muscles, those contraction or relaxation or the basic tones. Because the basic tones is the key to the balance of anatomic, and the anatomic, whenever it's normal, it can help us to have a normal range of the function. Help the patient to adapt quickly and in the new environment, reducing even the symptoms in the patients in the post-operative. It can help to reduce the symptom, sometimes even to treat them definitively and to improve most of the quality of life. But how are we going to do the post-surgical major surgery pelvic floor rehabilitation? We need first to get the full assessment after the surgery. How is this patient after surgery? To evaluate, assess the impact of each symptoms on her quality or his quality of life. I would like to understand how much the stress incontinence affects your quality of life. I will ask the patient to give me a score from 0 to 10. I will ask the patient how much that pain or any kind of symptom I will assess. And then I will brace the treatment planning according to the patient's, and then I will explain how we're gonna work together. If this patient has come before surgery and got such an indication, it's gonna help me because the way you see, after surgery, we need to come back to this. So if we did it earlier, we will gain some time. I mean, timing here is not the timing when it's come for the treatment directly. We gain the time because the patient has already understood and knows how to control a little bit. Now we will just try to work through that path. Involve and encourage our patient to take part actively. Remember, the patient should never take the treatment passively. The patient must be actively involved. You and all the tools available, we should try to explain to the patient and use them. I will use them. Here it is use all the tools available, okay? Let me manually, electrical stimulation, biofeedback, I will use all the tools available. And then I will always start with the simple ways before I go to complex. I will always use statically, sometimes most of it, later on I will go dynamically. I will start to use such a technique so that the patient will understand how really to work. I will never give up, even sometimes when it's so difficult. I will try to work in a multidisciplinary approach, communicate with the surgeon, with the patient, and all the others who can help this patient, whether it's psychological and so on, to bring them together, the patient in the center. And then we will try to improve and then make sure that we can be successful. Some of these surgeries, whether it is transvaginal or using vagina tape surgery, whether it is prolapses and so on, they help to cure the disease immediately. But it's so important to see, to understand that these things we put here sometimes can have some side effect, the erosion, pain. So it's so important to assess and evaluate before such a surgery, but also to help the patient recover after such a surgery. I will give you here a case of a deep chronic pelvic pain, the treatment of electrical stimulation of some of my patients I have. This is a patient I saw just 1 week ago. She was 30 years old. The woman arriving after the chief complaint of deep pelvic pain. She came to see me in the static pelvic floor consultation in my hospital where I work. And then I did my clinical exam. What I found, she has a hypertonic and the right deep pelvic floor muscles. Hypertonic, it is very tough. Most of the time it's asymmetric, left and right are not the same. And the pain felt in the region of the alco canal of the penile nerve, as well as the tendinous arches of the fascia in that region. Like if I look to the right side of the patient, it's gonna go, for example, from the coccyx up to the up here about 7 to 8 o'clock, that line. You go to the alco canal, and then you put your finger in that, following that way, you will find the patient is hypertonic and the pain is very clear in that region. So that was one example. How can I treat this patient? Most of this treatment, this patient, we cannot use surgery for that. You have to go to that region and help these muscles to relax. And how to do that, I can use manually, I can use electrical stimulation. Later on, I will show you the doigtier, we call it the doigtier, a kind of a prop I put on my finger. I use electrical stimulation, tense, antalgic, analgesic, combined with relaxation, for example, and then use the massage and help this patient to relax. Because when I relax these muscles, I will try to reduce the nerve entrapment, so I am efficient in such a treatment. Such techniques, physiotherapists, they learn them, they have these tools, and these tools can help them to improve the quality of life of these patients. It's so important to integrate that. Such a case is common in obstetrician and gynecologists. We have also male patient, for example, who comes with suffering from the penile nerve. For example, those who do the cyclists, bicycling, professional cyclists, these ones, they have also the penile nerve entrapment for so long. They have been placing on that region. They have deep pelvic floor muscle pain because it's too hard inside. Muscles are not relaxing anymore. The inflammatory reaction is there continuously. So it's so important to go there to help them to relax. But we cannot just do it by injecting the drugs or cutting the ligament free. When you cut that ligament, you are going to create some instability in that region. It's going to be also another problem. So this is a probe I was talking about. I use with the device I use, you know, you have these two metallic is electrical anode and cathode. Electrical stimulation will come here. I wear my gloves and then put my finger at that region, and then I will go sending such a current, and at the same time using the manual massage. So I'm using two techniques combined, helping my patient to recover. Some of the patients, they have asymmetry left and right, whether it is flat foot. This can create it, internal rotation of the knee, internal rotation of the pelvis, and that will create it unbalanced left and right. It's gonna create also the tendinous arcus in that region. Muscles will become hypertonic. The same way the levator ani will become hypertonic in that region. Left, right side of the patient will have the pain. So you see, the problem can come from extra pelvic, but created the pain. The patient comes to you with dyspareunia as a chief of complaint. But the origin is because the left internal rotation of flat foot created such damage, but the pain is felt where inside the pelvis, the center. We use drainage current to help also regain control, to help this patient using movement, running and jumping at the same time. All of these adapting according to the social life, using different kind of curves, helping this patient. Here we use the pre-contraction. It's so difficult using my finger to capture the pre-contraction reflex because it's happened at 1/10 second earlier before coughing. How can I tell if really it's happened just 1 second, 1/10 second earlier before coughing or not? But by using biofeedback, I will be precise when it comes to the timing and the chronology. Here you have the pelvic pressure, and here you have the abdominal when the patient coughs, and then you can make the differences. All of these help us to understand better and help the patients. You see this video last time I even show you. You see,
I asked the patient to walk normal, and I explained using biofeedback what is happening in several occasions. During a bad posture, I show on screen that the line reflecting the pelvic floor muscles contraction is descending. That reflects that in this bad position, there is a lot less pelvic floor muscles activity. Then I ask to walk correctly with a good posture, and I show on screen how the pelvic floor muscle activity increases. Then walking more quickly, even more quickly, starting to run, how this reflects in increasing activity. Now the patient is instructed to bend as if she would pick up some things, show and explain the contraction she would learn to do. So pelvic floor muscles contraction during bending and stretching, getting up. She should learn the importance of contracting the pelvic floor muscles tightly.
Excellent. As you could see in this video, good posture is directly connected to the pelvic. So pelvic is a central part of our body. Whenever the things has changed, those things can affect really the deep pelvic floor, because our fascia anteriorly and posteriorly fascia, myofascial chains, they cross together anterior and posterior at the pelvic site. That means a bad posture will affect the tones and the contractility and the pre-contraction reflex of my pelvic floor. Everything is interconnected. That is why our major surgery in the pelvic or outside the pelvic or our behavior can directly affect our quality of life. Later on, we put the patient in the situation.
On the cross trainer, I guide the patient during the exercises, looking on the biofeedback screen for a pelvic floor muscles contraction. Instruct to contract and relax. Once again, instruct to continue the exercise, imagining she needs to go to the toilet, but that this is not so close by. In this situation, she should contract the pelvic floor muscles sufficiently to hold the urine and to hold the contraction for several seconds until she reaches the toilet and feels safe to urinate.
You see, all of these just tells us in a normal condition, maybe we never thought about it because everything is normal. But our patients are really having a challenging task and time to just control the simple basic. This is the basic, everybody needs it several times a day. How can you live in such a life if you cannot control such a condition which are directly connected to our quality of life? So you see, these videos just show this is how we reinforce our training to help the patient before she goes back to her normal life. Imagine your patient who undergoes such a major surgery and now who is able to do such exercises which are very difficult, but in a good manner. So this patient after such a surgery, because she gained a pre or post-surgical treatment, then this patient will really have the benefit through such a surgery she or he undergo. This is why it's so important to integrate these techniques, helping in France, a lot of cities, hospitals, including the hospital where I work. We often have multidisciplinary meetings with a lot of doctors coming from different specialty, gastroenterologists, urologists, physiotherapists, pediatrics, and then all of these guys, we work in a multidisciplinary approach whenever we have a case, because most of the pelvic floor cases is not just one symptom, sometimes different symptoms together, they work together. So it's so important. This article, for example, here in Cochrane, you know, they were talking about the relationship between the integrated and the pelvic floor function and the covering of the continence after laparoscopy prostatectomy and the effect of the event of the pelvic floor. We have also a lot of articles in the Cochrane. I found that whenever you have time, please feel free to go to read. You can understand that people now started to integrate different kind of techniques together, combining, helping to try to assess whether they work or not. But how do we know if we never try or do the research in that field? This article also very interesting, which about the curative efficacy of lower frequency electrical stimulation in preventing urinary retention after the cervical cancer operation. And in such a way, you see the low frequency, here they use after surgery, electrical stimulation is more efficient than a conventional intervention in preventing urinary retention after radical hysterectomy. It shows that how it's helped this patient after such a major surgery to recover in a good manner. The effect of transcutaneous electrical stimulation, nerves stimulation for the postpartum dyspareunia patient, just like the case I was talking about. And this one, the effect of the different hysterectomy methods on the pelvic floor function and the androcan base of the large data diagnosing the treatment. This is very interesting because they use different kind of surgeries. How do the hysterectomies, how do they affect the functions of the organ? The key topic we are having today is about how these major surgeries can affect, especially how can we treat them pre or post surgically to help them to improve the quality of life. Another article is about the effect of the transcutaneous electrical stimulation treatment on the lower urinary tract symptoms after the class 3 radical hysterectomy I was talking today. And then they use these protocols to try to see whether they help this patient after surgery to not have urination retention, for example, bladder retention or urine incontinence or even anorectal dysfunction in some ways. And then this one also was talking about the beneficial of biofeedback assessments on the pelvic muscles training in patients with the urinary incontinence after radical prostatectomy. Use this one also. They did such a research. If you have time, please feel free and to go and read it. This one as well, you can see all of them, they are enlightening different kind of techniques applied whenever it's come to pelvic floor rehabilitation, helping these patients, especially after they underwent major surgeries and improving their quality of life. On my conclusion today, I will finish just by saying that surgery remove the tumor, restore the ligaments, and try to have this patient to have a normal by using different kind of technique, including using the mesh. I would like to say also, through its trophic action, pelvic rehabilitation prepare the tissue, re-strengthen different kind of reflexes and muscles functions, and helping these patients to remain in the normal tones so that the prolapse might not occur, helping the bladder and the urethra remain in a normal range or cohabiting, living together in a very nice environment whether it is stable, and improve the surgical recovery. Also, I would like also to highlight here, rehabilitation restore also the pelvic tones. So important, the stability of our pelvic organ in the movement is based on the tones of our pelvic, and this is coordinated directly with the pelvic floor muscles as well as the ligament and the fascia. Surgery has restored the anatomy. If nothing is done in long term, if the reflexes are not there, if the muscle tones are not in a good range, everything will drop. Few years later, the patient might have the vaginal vault prolapse or any others. Rehabilitation restore also the pressure and equilibrium. That means the stability between intra-abdominal, I can even go further, thoraco, abdominal, pelvical, and postural way, so that the intra-abdominal and pelvic pressure can remain in a normal range. And further, I will say for major pelvic floor surgery, better start the treatment planning before surgery. That means the pre-surgical treatment is so important. Always work in a multidisciplinary approach. I will finish now, if you don't mind. I have been using about exactly 2 hours to share with you this wonderful topic, which is about the pelvic floor pre and post-surgical treatment. How can we help these patients to improve their quality of life and regain control? If you don't mind, I give you the voice there. The ball is on your side now to try. If you don't mind, I can go through the questions.
We are really thankful. Such a really excellent presentation again, as around more than 2 hours. I am really sorry that we made you tired.
No, I am not tired. You know,
Really?
I got some electrical stimulation, so no. Don't...
Okay then. So we can pass directly through the questions and answers then.
Let's continue. I'm not tired, and I know it's in the evening in your side as well here. It's better to finish so that everything is clear for everybody. So I'm going.
Everybody stayed till to that time and listen to you. So that is why we are really thankful to you. And we can pass directly through the questions then.
Let's go to the question and answer, please. So I first, the Bursin, the question from the, thank you, Dr. Ndongo, for your precious lecture. We are very happy to listen to you again. I am happy to listen to you. Thank you very much. My question is, this is a question, is that when the pelvic floor rehabilitation should be started after radiotherapy in prostate? I mean, the patient who undergo radical prostatectomy, or after they went a minimal TVT or sling, or after they underwent radical hysterectomy? Is a very, very good question. You remember in my speech, I was saying that we need to work in the multidisciplinary approach to help this patient to recover. So here, the question is the timing. After a TVTO or a TVT, when this patient can undergo, remember the vagina suture, when we use this suture, resorbable ones, in a few days, I can say 15 days, 3 weeks, most of this suture is gone already. So in a month after surgery, just a month after, we can start it. Remember, the pelvic floor rehabilitation treatment is very simple. Sometimes we do not need to go there and touch or do other things. We can just put the vagina probe and ask the patient to contract and relax. I can try just to strengthen these patient's muscles by using biofeedback. If it's necessary, I can go electrical stimulation. There is no side effect in such a way. I'm not going through these techniques 3 days later, but I just take 1 month, for example. In France, for example, most of the time after a major surgery, we see the patient in a short term, like, okay, the patient has been in hospital for 2 days, 3 days, 5 days. When the patient goes home, after 4 or 3 days, she comes back. We see her, we do the assessment. Later on, we see this patient 1 month later. Why? Because we have 1 month, the recovering almost is complete. Then we will start. If you wait too long, some of major surgeries, especially the scars, for example, if we have, I give you one example, cesarean section. You know the cesarean section, after the patient in 2 days, 3 days, she's at home sometimes. But we ask the patient just to start to do the massage on her scar. Manually, we teach the patient just about 10 days or 12 days, the patient starts to use manually. Of course, the scar is clean and is curable. That means there is no infection and other thing. This patient in just about 10 days to 12 days can start to do superficial local massage treatment. So in the pelvic floor, it's just the same. When you put the vagina probe or when you put for electrical stimulation by feedback, 1 month later, you can start the treatment without any problem. You should not wait 6 months later. 6 months later is too long and it does not help. This is why sooner, better. When I mean sooner, there is no reaction. The doctor has seen the patient maybe 1 week later. The scar is clean. Everything moves in a good way. You work in coordination with the doctors. After 1 month, that means 3 to 4 weeks, you can start slowly to help your patient to recover. And this will help a lot. If you wait 2 to 3 months, the inflammatory reaction, fibrosis, pain, all the things will start there, and it's going to be very difficult to reprogram it because you will have some obstacle which will affect the quality of your treatment. So remember, the timing here, I will say 3 to 4 weeks later in major surgeries. When it comes to the scar superficial, about 2 weeks manually, you can start to stimulate. But when it's in the deep pelvic floor, same way, you can 3 to 4 weeks, I say 1 month, for example, you can start your pelvic floor rehabilitation treatment, especially if the patient has a pre-surgical assessment and then you talk, you can start with biofeedback slowly, you put electrical stimulation, you go from manually helping the patient to regain the control and then to reinforce all of that quality of work. Thank you very much for your question. Another Dr. Osdal asking about, dear doctor, do you have some criteria or clue for yourself in order to decide for pre-surgical or post-surgical biofeedback? Here, it's an excellent question. First of all, if you really understood what I say here, first of all, when we do the biofeedback, as you know, today, as I presented, I talked about the tonic fibromuscles, the type 1, the tonic. I talk about the type 2 as well, if you remember, the phasic and the intermediate. So in the biofeedback techniques, we have, for example, the endurance one, type 1. We ask the patient to contract about 40 to 60% of the capacity of the maximum, okay? First, you ask the patient to contract maximum. For example, the maximum range goes up to higher, up to, let's say, okay, 30 microvolts. The pelvic floor in general is about 40 microvolts. So if your patient underwent 30 microvolts, so you ask your patient to contract halfway, 50%, for example, that means about 15 microvolt, the height of the biofeedback, and you ask the patient to keep the contraction, maintain. Here you are working on the tonic fibromuscles. So we do the tonic fibromuscle exercises. You ask the patient to repeat it several times. And then we ask the patient to do the phasic, that means like the type 2B, the maximum contraction and relaxation, and then maximum contraction and relaxation. That means the patient here should contract about 30 microvolt, the maximum, the range, so that you should work with the tonic and phasic together combined. We have also some exercises, which is tonic and phasic combined on the screen. That means the patient will contract about 40%, maintain 40%, and peak, you do some peaks on top of that 40%. You have 40% of tonic combined with the peak of phasic, you have tonic and phasic. Because in general and in normal range of our quality of life, normal life, tonic and phasic, they work together to have one function, which is enable us to control the urine, to control the defecation, to have a normal life, normal feeling. All of these are combining with the tonic and phasic together. Everything I've said here is valuable for the deep pelvic floor muscles as well as superficial pelvic muscles. We use different kind of tools to help us to go to deep and superficial. When it is on the surface outside, we can use external electrodes. Same way, tonic and phasic. So we use all of these. These techniques are not just mine. They are well known in the worldwide, published in different guidelines. Okay, they are not my techniques which I created myself. So, but you should understand the choice of the shape is depending on the patient capability. It's not I decide. It's yes, I will train the tonic, I will train the phasic. Now I will choose according to the height of the patient. Some patient, it's only 12 microvolts. Others is 15, others is 20, or others is 30 microvolts. So I will, according to their capability, I will choose the shapes and help this patient. If the patient can only contract 5 seconds, for example, of tonic, my aim is to help the patient to go 6 to 7 seconds. Can you see? If the patient can contract 5 peaks for phasic, my aim is to go to 6 to 7 peaks. This is how I will improve the endurance and I will improve the different kind of contraction when it comes to before coughing, the pre-contraction reflex, for example, so that the patient might not have the link of urine, and then reinforce beside the strengthening the muscles. You should never forget the reflexes, which is the myotatic reflexes, which can be achieved, for example, with the pelvimeter. We call it dynamometer. We know between 5 and 6 degrees of the opening of the dynamometer. This is when the pelvic floor myotatic reflex occurs. So if your patient do not have it, you will also reinforce the tonic and the phasic so that you can regain the myotatic reflex, which is very important when it comes to the control, to the continence functions. So I hope I have answered your question, and thank you very much for that question. I will go back to the next question here. Here we have Sema. Sema said, hello, Dr. Ndongo. I would like to learn about multiple sclerosis patients. Do you think this patient group is able to get benefit from pelvic floor rehabilitation after attacks? Thanks for an amazing presentation. Thank you very much. Of course, we, even in France, we have patients with multiple sclerosis with different kind of inflammatory reaction and pain in different parts of the body. So remember what we talked today. You see, I talk about different tools which can be used to help our patients to regain control, whether it is vascular system, whether it is inflammatory reaction. All of these inflammatory reaction in that region, whether it is joint, whether it is in locomotor, I'm talking about musculoskeletal, the whole body, everything is interconnected. The pelvic floor, I was talking, yes, the topic was more focused on pelvic floor rehabilitation, but we can apply it in a different part of our body. Because of, imagine you have these patients who have peripheral nerve damage partially, which interacted with a local inflammatory reaction, which interacted with muscles loss, atrophic and function, which interacted with the pain, for example. You see, if the patient symptoms is connected to the pain or muscles atrophic, you can help this patient. I'm not saying cure completely, but you can improve the quality of life by relieving the pain using, for example, the TENS treatment. For the muscles atrophic, you can do the drainage, local drainage, which will help not only to waken up all the fiber muscles, but as well as to remove the inflammatory local regions. So we use the drain, not only to drain, to bring the in and out cells, you know, the exchange and blood circulation in the region. That means also to evacuate the different kind of ion, positive ion, which created local inflammatory reaction. So we can help, we use these techniques in different kind of trauma, whether it is post-surgery or not, or whether it is in such a major pain or major trauma or disease, which can affect a different organ in different ways. So we help the patient, for example, low back pain, those patients who come with that. You can relieve the pain using the massage, improving the posture of your patients, and then relaxing those muscles become hypertonic. How I do to relax? I can use manually to try to relax locally. I can use electrical stimulation, we call it tonalize. It's a low frequency, 1 hertz, wild of pulse between 150 to 350, for example. You use such a one frequency of hertz, such a pulse, and then you will gain not a very much contraction, but you need just to have like the blood pulse. The blood pulse, that is enough to relax and hypertonic. So you can use such a thing, not to cure completely the disease, but to improve the quality of life so that the patient can have her basic days and life, a normal life, close to the normal life like anybody. For example, another question which says that, for example, do you recommend biofeedback treatment before LAR, before stoma closure or post closure of the stoma? Of course, I talked about it, and you know that if you remember what I say, the aim of the pre-major surgery in the pelvic floor, the aim is to inform the patients about what's going on and what kind of complication might occur. We educate, we prepare. This is psychologically. The patient learn, now the patient will be prepared. If you don't learn, if you never heard about it, it's going to be very difficult. Secondly, such a surgery, as I told you, it will create such a surgery, it will create some changing in anatomically. So my pre-surgical treatment before stoma, before that patch, we put it after anorectal this surgery in the patient who has cancer, for example. What do we need to understand is when I do such electrical stimulation just before surgery or just biofeedback, the patient will memorize on how to contract. You know, as you know, pelvic floor is not well developed neurologically compared to our hand. You know, our hand we touch every day. They are well, trained. You know, the sensitive is well developed. Even after trauma, we manage quickly to regain control. But the pelvic floor is not the same. So we need to use such a procedure to create a kind of memory, a kind of a connection between the pelvic and the brain, so that this patient at least knows how to contract after surgery and how to relax. Now, after trauma, remember, most of the time when they have the stoma, they are not going to use the anal region for so long. If they don't use it for so long, it's become atrophic. So pre-surgery here is just to put, for example, external electrodes, just put external electrode, give the sensation on how to relax. Because after surgery, you will teach the patient contract and then relax, 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 relax. Such a treatment, such a way of treatment will help the patient to learn how to relax that region, which risks to become atrophic after long period without having anything passing through that region. So the pre-surgical treatment, inform the patient, educate the patient, prepare the patient, and also give the tools to the patient so that post-surgically, the patient will be able to manage and to gain control and to try to bring back the life. And you remember that each surgery is different. The effect of the same surgery on different patients is not the same. It depends on the range, the size, and the attempt, and especially the nerves which were damaged in that region according to the history. Don't forget, each patient before such a surgery had a history, whether it is good behavior or bad behavior. So all of these sum up, becoming an obstacle post-surgically, which the patient need to overcome. So if the patient came before surgery, you find that the patient has a bad habit of constipation, for example, before even surgery, you will explain such kind of anal, dysynergia, constipation, or the transit, the behavior on alimentation, how to eat and how to drink. All of these, will help your patients to well trained, well prepared, so that the recovering process will be short, and then the quality of life will be achieved and then acceptable for this patient to have a normal quality of life. So thank you very much for your wonderful question. And then thank you, doctor. Is there any indication for biofeedback physiotherapy on the bladder and the spine cord injury? Yeah, this is also a very good question. A bladder and spine injury. You should understand just one thing. One is, I said it maybe quickly. I said if it's complete nerve damage or partially damage, everything is based on that. If you have a complete section, it's gonna be almost impossible. Okay, the nerve is completely damaged. But if it is partially, and if the patient has some sensation of feeling to void, for example, or to go to toilet, there is a sensation, then we can try to improve such a sensation and regain a normal quality of life. So my key point here is how to improve the sensation in the post. I know some patients who really are struggling by using the techniques of electrical stimulation and biofeedback. Slowly, they start to regain because they have to adapt to a new environment. Sometimes, you know, it's just like you put on the scale. Who will win? If you leave everything and you had some chances to recover, but you do nothing, these chances, you will lose them. The disease will become heavier than the chances for you to control. But if you have the chances to control partially, and you use those chances, sometimes the body can adapt and create some new sensitive, new reflexes, let me call them like that. These new reflexes can be, for example, the timing. The patient should decide when should he or she go to pee. When is it the time to go to void? And how to void, how to relax. It's becoming a new process of learning, so the patient will adapt. So you see, the pelvic floor rehabilitation is also a way to help the patient to regain new tools on changing their behavior, adapting to the situation, and helping them, those partially nerve damage, to try to recover in a good way. So I hope I have answered to your question. Thank you very much. I think I answered all the questions which were on the Q&A questions. Thank you very much, Isaac. Do you have any other questions or any remarks?
Questions, you answered all of them. It seems we really appreciate it, and we are receiving comments from our participants that they are thankful to you. And hopefully we will be again together in our next session, which we will define the subject. Maybe evaluations, who knows, huh?
With the will of God, we will meet again.
Yeah, we will talk about later on, and we will announce our participants once more. Maybe next month, we will be again all together.
Yes, so thank you very much for your listening. I would like to thank everybody who, from far, I cannot see all of you, but I can feel your energy again. So thank you for being here and to staying so long for more than 2 hours and a half. If I look to my, yes, exactly 2 hours and a half. So I would like to thank all of you for being there from all parts of the world, especially friends in Turkey, in Istanbul, in Ankara, and in different parts in your wonderful country. Thank you very much for inviting me again. And thanks to all my friends all over the world. And I hope to see you next time. Thank you very much.
Thank you. Thank you very much.
Shukran. Shukran. Have a nice day. And good night. Thank you.
Bye-bye.
Ceze, zaijian. That is in Chinese. It means thank you and goodbye, all of you. Thank you.
And I am also thankful for all our participants. They stayed till to this hour, and we really appreciate from their attention. Thank you very much.
I appreciate that. Thank you.
Bye.
Thank you very much. And God bless, and see you next time.
See you next time.